participants. And then, of course, where does all breaking news appear? In the New York Times. An initial analysis of the data in 2001 showed that there was an increased risk of heart attack and stroke in women who were in the treatment arm, the estrogen or estrogen and progesterone arm, versus the placebo arm. So, just like we did when we were in medical school and residency, the doctors told all their patients, you have to stop it. And we had patients come saying, but I don't want to stop it. So rather than going through the data and saying, okay, these are the risks, these are the benefits, what would you like to do? We said, no, sorry, we can't do it anymore. It's not good for you. I don't care if you think it's good for you, you're wrong. So for a good 5, 6, 7 years, there were some fringe practitioners and fringe patients who managed to go outside the major system, would go to compounding pharmacies, or would be able to somehow finagle hormone treatment for the ills that they had from their hormonal changes. But by and large, the medical community just said, no, you can't do it. And in fact, unfortunately, the medical community is still saying that. But there was a paper published in the New England Journal back in 2007, which New England Journal of Medicine, of course, being like the Bible for American medical journals. And these authors demonstrated, if you go back to the Women's Health Initiative and look at the way that the initial study was designed, and look at the women in the treatment arm versus the women in the placebo arm, there were more women in the treatment arm who were 70 years of age and older. There were more women in the treatment arm who had high cholesterol to begin with. And if the data is reanalyzed...
Right, statistically, they were at risk.
They were really... So women in the treatment arm were at higher risk for heart attack and stroke to begin with. Not even approaching yet, but we'll get there, about the fact that all these women were treated with oral progesterone, or oral estrogen, which was not bioidentical. The estrogen was derived from horse urine. And there was no... Back then, with hormone treatment, there was no approach to individualizing treatment. Everyone got the same dose because, once again, we knew it was better. So when they went back and reanalyzed the Women's Health Initiative data, it was shown that the increased risk of heart attack and stroke occurred in women who started their hormone treatment more than 10 years after the onset of their menopause. So, you kind of have to take the safety and efficacy data piecemeal, which really is actually, when you think about it, is what medical research does. There's no coherent, there's no design to medical research. Different investigators decide to answer a question, and they answer a question.
The way they really
and
want.
really what we do is we have a constellation. We have a constellation of different information sets that we then look up at the heaven and we say, oh, let me connect the dots, and this is the picture I got. And we forget that it's really just a constellation. And there's nothing that makes medical researchers any better at making figures out of stars than other people. But instead of explaining what the stars are and helping people come up with the greater design themselves, we just tell them what the design is.
Right. Because nobody looked.
No one looked. And so they showed the first thing was that women who started their estrogen treatment within the first 10 years of menopause had no increased risk of heart attack and stroke. So the problem was that estrogen, as it was given in the Women's Health Initiative, oral estrogen, is in fact prothrombotic. Gee, isn't that terrible?
Like we didn't know that.
Yeah, right. So we can't use it at all, or we can't use estrogen at all because oral estrogen is prothrombotic. And gee, what a surprise! And so, first of all, so women who even started oral estrogen within the first 10 years did not have increased risk of heart attack and stroke. The issue of what to do in terms of estrogen and progesterone replacement in women who want to start after the first 10 years of menopause is more problematic. But I think then we have to look at what the risk is and what the benefit is. What is this individual patient's risk of coronary disease? And what are the problems she's experiencing as a result of the low hormone levels? What would the benefit be that she can expect from optimizing hormone levels? It's not replacing it back to premenopausal levels, but we know that there are levels that we can reach which are safe. We also know that if we don't use oral estrogen, but if estrogen is given transdermally, that is, if estrogen is given across the skin, either as a patch or as a cream, there is no increase in thrombosis. So the thrombotic risk is minimized. In fact, a study showed that women who took who had a transdermal estrogen treatment along with an aspirin a day, that those women had lower rates of thrombotic episodes than women who did not take any estrogen alone. We also know that we can use estrogen medicine and we can draw blood. And we can actually measure estrogen levels in the blood. And there are studies which show at what levels do we have more side effects, greater side effects, greater side effect risk, and at what levels is it safe.
What do you think about saliva? I get a bunch of patients who come in and I want my saliva testing because I read Suzanne Somers' book, and she said...
Saliva testing, I think, has a great deal of promise. In my practice, I use saliva testing to monitor 24-hour cortisol levels to get an idea of not just how much cortisol someone makes in the morning, which is kind of the gold standard approach in the way we were taught, but I look at what's the pattern of cortisol production over the course of the day to see whether these patients are actually producing cortisol in the proper sequence, or do they need to have that reordered, because there are a great many symptoms which can accrue from that.
You'll have to come back and do another show about adrenal fatigue.
Okay, we'll promise
we'll
talk about adrenal fatigue.
That's another hot topic.
No, it's very cool.
It's a very hot topic.
Yeah. So saliva testing is good. I don't think there are enough studies showing that it measures up to the gold standard of serum testing for estrogen and progesterone, and testosterone and DHEA and even growth hormone. But there are enough people using it that I think we're accruing the experience, and we'll know within a reasonable amount of time, whether it's going to be 5 years, whether saliva testing will take place.
And it's also a lot easier if you really want to measure levels in a 24-hour period, because a person can't live in your office, whereas they can do the saliva test.
And it's a very, very simple test to do. It's really simple.
Chew that gum.
No, it's not even that gross. You have a little straw, you sort of spit through the straw into a little tube, very little bit of saliva you need, and you just put it in a package, you mail it out. It's great. So those were some of the data which we've learned about hormone replacement in women. And there's even more data looking at not just the benefits of estrogen and progesterone replacement in women, but even testosterone. Women have testosterone. Testosterone in women falls as estrogen falls, because testosterone comes from estrogen. Just as testosterone falls in men, testosterone falls in women. And testosterone has a great deal of benefit for women in terms of cognitive health, in terms of maintaining lean muscle mass and helping metabolize fat.
And libido.
And sexual health as well.
Big issue
and we know that's really important for overall health. It's libido and sexual function is a reflection of health. If we're not in good health, we're not going to have much libido. So it's useful for that. And then when we have a really active sex life, it helps cognitive health and all other forms of health, blood pressure, everything. So testosterone replacement is important. DHEA is a hormone which is amazing. DHEA supplements are not even regulated by the FDA. So people can go in and buy whatever strength of DHEA they want without knowing how much they really need. And there's no control over quality. There was another study which looked at DHEA supplements that were available over the counter, and 5 of the products didn't even have any DHEA in them at all.
Right. We use a compounding pharmacy for the DHEA that I prescribe for patients, because this way you know how much you're getting, and you measure their levels, because you may need one amount, I may need another, obviously.
Exactly, and people respond differently. And then the interesting thing I found is that people can start off with low DHEA levels, and as you optimize all the other hormones and help them sleep better, it comes up. So you often have to adjust how much DHEA they're taking. But studies have shown that low DHEA levels are associated with higher mortality rates. Studies show that lower testosterone levels are associated with higher mortality rates. People get so scared about growth hormone, not realizing that growth hormone is something that's good for us. We need growth hormone in order to function optimally. We don't need too much growth hormone. That's not good. But people, adults, just like people can be missing thyroid hormone and need thyroid supplementation, just like people can be missing insulin and need insulin supplementation, people can be missing growth hormone and need growth hormone supplementation. And yet, people feel that that's wrong. So
I think it's the publicity, because when you look at growth hormone, if you go on a site, it's scary, because they give you all the side effects and how you should really have a lack. It's almost as if you really need to have or have a condition where you make no growth hormone, and that's the only person who needs it.
That's actually an interesting point, because if the only thing that someone wants out of health is to never have cancer, to have zero risk of cancer, there are 2 studies I know of that show that lack of growth hormone is, I guess, a good thing. There's a tribe down in Central America, South America, which has no growth hormone and no cancer. The only issue is they're all pygmies. And please, I don't want to offend anyone who's a pygmy. Right. It's fine, but it's not our average. It's not our average state of health. There's also they developed a breed of mice with no growth hormone that never got cancer. The issue was that if you took these mice out of a temperature-controlled, environmentally controlled, food-controlled environment, they died.
Right, but that's the point. You have these people who are in South America. It may not be just the growth hormone. It may be their diet. It may be the indigenous plants that they're eating. There's a lot of factors that go into that to make that claim that don't